Öğleden sonraki bu ilk oturumun konusu hasta klinik olarak tam cevabı aldı ve bekle görü kabul etti. Bundan sonrası ne olacak? Bu konudaki ilk konuşmacımızı davet etmek istiyorum. Doktor Beets. Hastama ne söylemeliyim? Bekle gör standart bir yaklaşım mıdır? Yes, Dr. Beets, it's my pleasure and honor to invite you to the platform.
Hello, this works better. This is more a short philosophical talk than a lot of science in there, but so I'll just tell you how I'll discuss this organ preservation with patients. So when I was trained in school, it was all about medical knowledge and not so much the other elements of shared decision making. And then later we were taught, and we are teaching our students now, you should communicate with patients and tell them. It's not just in your head, but you should explain and tell the patients. So the medical knowledge part, that is evidence-based medicine, and there's two parts in there. There's the evidence, and there's a lot of focus on the evidence. Is there any level 1 evidence in watch and wait? No, there isn't. Because if you have level 1 evidence, that level 2, level 1, that makes it into the guidelines. So on watch and wait, we don't have that high quality evidence. We have limited numbers of single center series, and we pool them. But evidence-based medicine is not just about evidence. Actually, the guy who invented this Sackett, he got a little disappointed with the way it was interpreted, because he said evidence-based practice, you need to have the best research evidence that is there, but to use it in practice, you have to use your common sense, your clinical expertise, and talk with the patients and add this to the mix. And that is not just simply following or implementing a guideline or saying we have no level 1 evidence, so we can't do it. So communication is also not just talking to the patients, but you have to, if you want to hear what the patients want, you have to actually listen to them too. So what do I tell the patient? I want to add to the title, and what are the patients telling me? So I tell the patients not just this is what the standard treatment is. I always tell them about the different options. And in our MDT meetings, often when we're discussing on a case a little longer, I put up my hand and I say, well, apparently we have more than one option here. So now in our MDT meetings, we often list 2 or 3 options. We say number 1 is this, number 2 you can discuss this, and even number 3. So there doesn't have to be one single best option. So you have to discuss this with the patient, but also the non-guideline or non-standard options. So I mentioned these to the patients, and then you have to discuss the pro and the cons about these options. But if you have to discuss this on 3 different options, a 10-minute in your office is not enough. It takes longer. So watch and wait patients, I take my time, because you have to tell them estimates about the chances for cure, for regrowth, for metastasis. You have to explain them about the functional problems for the one approach, for the other approach. You have to explain them complications of surgery, complications of chemoradiation, because if you're going to give chemoradiation to a small tumor with the intent of organ preservation, chemoradiation has its side effects. It even has mortality. It's not much. It's 0.5 or 1%, but you have to tell this. And what I tell patients about the oncological outcome of a candidate for the watch and wait approach, if I do think the patient has a complete response, I tell them that we are right 8 or 9 out of 10, and that they have a chance that they would still need surgery after a while. But I tell them that in our experience and in the series that we have, they don't run a big risk, although we're not entirely sure, because according to our scientific standards, it has not been proven. But in our experience, we don't think they run a big risk. But you have to explain this to them in a way they understand, and that's not always easy. Often patients want to avoid desperately a stoma while they don't have a good idea of what a stoma is. You have to explain them or refer them to a stoma nurse or other patients. And then you have to tell patients about your experience. For me, it's easier in watch and wait because I can tell we have 280 patients, but if you're starting with it, you don't know, you have to tell them. And you have to stress the importance of follow-up, of early detection and follow-up. They have to be compliant to follow-up, because if they don't show up, they might run a risk. And then often, at the end, you get the question, what would you do, doctor? Now, I have to admit, I see a lot of patients who are already informed, who have written, who have searched the internet, and they are already informed with their ideas. But if you have a patient who has no idea that they might have a complete response, you have to spend more time. And what would you do, doctor? That's a difficult question, because I don't have rectal cancer. I wouldn't know how I would do it, and I don't know what their life looks like. So before answering that question, I'm going to ask them about their life, and 10 minutes is not enough in an outpatient clinic. But I often start off, what does your normal day look like? What do you do? So what is important for you? Some elderly people don't care so much about survival, but they want to stay independent. They want to stay out of the hospital. They don't want a stoma because they might become dependent. So, and they're willing to trade off some risk for that. But to understand this, you have to talk. At the bottom list, I've put family dynamics. I once had a couple sitting in front of me, and the guy was desperate to avoid a stoma. And we have been discussing 10 or 15 minutes. And I was quite sure that he wanted to be followed with a watch and wait approach. But then his wife said, okay, you had your talk. We have 2 16 and 15-year-old children. And if you think you're running a risk to avoid a stoma, you know, I won't have that. I'm not going to have the risk of me having to raise those 2 adolescents by myself. So you get your stoma. So how do you think that worked out? So the guy lost, of course. He looked very helpless. So I was not feeling very sympathetic with the wife. She talked to her husband like that. But this is all, you have to account for all this. And if you don't take your time, you don't know. I have found that patients are extremely interested in this, and patient organizations, they promote this, and they tell. I've already shown this picture of my patient who wrote a book, the bestseller. So what did I learn during these 16, 17 years? So I was still young there. When you're a young surgeon or a resident, you're interested in surgical technique. A little later, the next 10 years, you learn about the disease. And regrettably, I have to say that when you have a little gray hair, you actually start thinking more about this other element of your treatment. It's the patient. What do they want? And if you're more concerned about and you talk with your patients, then guidelines sort of sneak out the back door. I learned that you don't assume that you know what they want, but you can simply ask them. I mean, some young patients, you would think they don't care about the stoma, they want to survive, but some young patients are willing to trade off risks for that, and others don't. Ask them. Don't confuse your own fears with those of the patient. If you're afraid of death and dying and discussing about it, the patient may be very well capable of understanding it. And to my surprise, many patients are willing to trade off some oncological risk when they gain quality of life. Actually, that's something we have to learn to deal with. And sometimes you want to protect patients and you explain them, but if they persist in their wish, then that's their choice. And many patients, I try to let them take responsibility too for their choice. It's not just me. If a patient wants something that I think may not be the best, they're often quite capable of being responsible for their choices. Because when you come to think of it, what actually is a good decision is not what you decide, but that is the decision the patient takes, even if it turns out bad in the end, that they can still look at you and say, hey, that was all in the game. So I often literally ask patients, so if in 2 years' time this is not working, will you be mad at me, or are you going to regret it? So they understand. So I've shown this yesterday, I think it is. So in the patients' perspectives are often different. So we worry about the oncological outcome, and they say, no, you're not doing it unless you're absolutely sure. They're often more worried about the quality of life. In doing organ preservation, I've met an incredibly number of patients who are doing things themselves to help the tumor disappear. It's amazing what you see here. The thing I like best is the coffee enema. Have you heard of that? So I like this patient. This lady, she keeps coming in every 3 months, and she keeps trying to convince me that I should try it too. Because she doesn't need it anymore because the thing is gone. But she said, it's so nice, doctor, why don't you try it? So next time I'll ask her if she uses cappuccino or double espresso or what. And the way I deal with this, I don't argue with these patients. I only ask them, what does it cost? And does it cost you a fortune? I'm not sure. In the Netherlands, cannabis oil is, as you can expect, very popular too. So the thing if you have patients with the one on the right with large tumors that you give chemoradiation and that have a complete response, or you think these are the easy cases to discuss because there's nothing much to lose really. It's the ones on the left that are more difficult. Because you have to tell them, yes, you can turn out to be a winner, but you can turn out to be a loser. Because you get radiotherapy, it doesn't work, and you still need surgery, you're going to end up worse than you would have with surgery alone. So these are the difficult cases for me where I'm not sure. And so these are the patients I'd like to put in a randomized trial to find out. So I'm already at the conclusion of my short talk. So organ preservation is an option, is what I tell them. I tell them it's not universally accepted, but that I'm convinced that it will become a part of the normal treatment after a while. And I tell them that we don't have the regular scientific data, but we have some data that support that there may be an unknown risk, that we don't know exactly how much that is, but from what we know, that the risk, if any, the oncological survival risk is below 2%, which is somewhere in the order of the operative risk. So elderly patients with comorbidity, it's an easy choice. And you have to involve patients in the decision, and they're often more willing and capable to do so than you think. So take your time to do it, and as Pat said earlier, these are very rewarding patients because they come back to you in the clinic and they're so happy that it worked out very well. So that is what you get back from your time investment. Thank you.